So the question is, can we record now without interference, without any background noise? Okay, so
you click on the 1, 2, 3, 4.
Let's just see if that works. Hear me now. We are recording. So basically, welcome everyone. This is the first podcast that
Don't start with so basically. Don't start. That's a terrible start.
Okay.
Oh God.
We'll edit it out later. So this is Kash and Pete Bates from Barts and the Royal London Hospital.
Hi there.
The podcast is nothing to do with the trust, and they have no affiliation with it whatsoever, unless in the unlikely event it becomes successful, in which case they'll be all over it.
Yeah.
So Pete sometimes uses naughty language, so just to warn everyone listening that you may hear some bleeps. So,
that's nonsense.
So Pete, no swearing. Please don't say shit, fat or bollocks.
Okay.
So Pete and I run a Masters in Orthopaedic Trauma. If you go to Twitter, you can find us at OrthoMasters. It truly is masterful, and we recommend it highly. And basically, I like to think that we work collaboratively as equal partners.
We do. Yeah, in the MSc we definitely do.
But I think that a better analogy is that I'm the zookeeper, and you're the badly behaved monkey. And you're basically throwing shit at the wall and exposing yourself to the public and making children cry.
But you need both of those, right?
Yeah.
Otherwise the public don't come.
And then I have to get out there and clean it all up and apologise to everyone and say, I'm really sorry, but he's a monkey. What did you expect? But in all seriousness, it's a real privilege to work with Pete. And as I'm sitting here, I can see his aura. He's kind of glowing orange, like the Ready Brett man. So Pete, we haven't got a name for this thing yet. Have you had any ideas?
The Ortho podcasts.
So Ortho podcast, the Barts Ortho pod.
Yeah, the Ortho pod, that name's already gone, hasn't it?
It's gone, it's been robbed.
Been nabbed by somebody else. We should have gone there earlier.
See one, do one. Send for the next. In the coffee room. I'm not quite sure. Pete, can you just tell everyone about yourself? Because not many people may know much about you beyond the fact that you won BOTA Trainer of the Year, you got married wearing a toga, and you have an eye for designer handbags.
That's right. That's what everyone knows about me. Now for the lesser known stuff. I define myself as an orthopaedic trauma surgeon. I'm a guy who fixes fractures. I mainly stick to the lower limb, but I can fix a proximal humerus and an elbow. I can even sneak a wrist in now and then. But my practice generally circles around pelvis and acetabular and lower limb fractures. So that's kind of where my expertise is, if you like, in orthopaedic trauma. And I also really like that whole polytrauma thing, where you've got multiple injuries around a really messed up patient. Systemically messed up patient.
So basically, before I met you, I'd never met a pure orthopaedic trauma surgeon. I was just curious as to how did that come about.
Yeah.
Does it mean you're shit at elective orthopaedics?
Yeah, it basically does. Yeah. I could just never find an elective orthopaedic surgery that I really liked. We did these hip replacements, and I did a few, and they were fine. I think they weren't all limping, but they.
These are your tin hips.
Tin hips, that's right. Yeah, and then I tried tin knees, and they were okay. Again, I did a few of those, and that was fun. But it never really kind of cooked my goose, if you know what I mean. I never really felt that I was really cut out for this. By the end of my training, I found it really quite a boring operation. And when you're forced to do boring surgeries, you get quite cross.
Yeah.
I used to find myself getting a bit angry, going, what am I doing? This is ridiculous. I'm having to do another hip replacement. It's such a boring operation.
Why am I going to change this person's life for the better? Why am I going to give them their independence, their mobility back? Sod that.
It's pretty selfish.
Yeah.
It's pretty
Let's
selfish.
put them on crutches.
Me.
As long as you're happy.
I know it's good for you, but I really don't.
It really doesn't help me.
That's right.
This. And the other thing,
and I like the immediacy of trauma. I like the trauma's like you're kind of you're street fighting a bit, and you're every day's a bit different, and it's always got that kind of unpredictability, that everything's a little bit unsatisfactory. It's never quite as you would want it, and I quite like that.
And to be fair, that's why I enjoy the trauma, because in my elective practice, I probably do 6 or 7 operations again and again. And actually, I quite like doing them and getting really good and efficient at them. But the trauma is the thing that throws you. The trauma is the thing where no 2 operations are the same. No 2 operations are ever the same.
Yeah.
And that's where the challenge comes, right? And the fact is, it's a bit of freestyling. You are having to go, open me that bit of kit. Actually, I'm going to use this to do that. And it helps with your elective surgery if ever you're in trouble.
Yeah, it definitely does. Yeah, and it keeps you it just keeps you alive, keeps you open, and I agree with you. I think it does help your elective stuff as well. Yeah.
So I am by trade, but my day job is a knee surgeon. I do trauma. I'm on the major trauma rota here with the guys. I've been here 5 years now, and I tend to find now that that increasing with time, my trauma has kind of drifted towards around the knee.
Yeah.
It's not something I particularly asked for, but I found now my trauma lists tend to be...
It's because when people find out you're a knee surgeon, they kind of send you knee stuff, don't they?
Yeah.
And then suddenly you find your lists all filled up with like multi-ligament stuff and tibial
plateaus and intra-articular distal femur. I'd like to think it's because people think I'm really good at them, but it could just be keep away from the other shit. It's a nightmare. Just you know.
Oh my God, he tries to do a Liz Frank. Never again.
No.
Never again.
Just give him a scope and keep him happy. So
Kash, honestly, I think that's the way trauma's gone around the globe now, or going at least, is that people are feeling increasingly comfortable in their own subspecialty arena with trauma, and so more and more, the upper limb guys are taking the upper limb fractures, and the knee guys are taking the knees, and the ankles are taking the ankles. So the role of the generalist nowadays is they're still there, and you can do it, but it's becoming less and less of it, particularly in the level 1 setting.
I agree, and I think that's the only way you can strive to improve outcomes. In a trauma unit, you understand that there's more need for generalists. So I think within the major trauma centres, particularly when the general trauma surgeon is sending things on, and then I think you're looking for more subspecialty specific interventions.
Yeah, because these are quite difficult operations. I mean, a multi-ligament knee that's quite a tricky operation, isn't it?
I think it's the hardest operation in orthopaedics. But but I don't like to talk about it.
The only joint in the body that actually matters, the knee.
Everything else is peripheral, everything. So and then basically, so my background is that I've done a master's and an MD in medical education. I did a fellowship for a year in leadership and education, and then I did a year's fellowship in knees at Oxford, which I had a good time. Oxford, don't you know? Got some red trousers. And then I did a Winston Churchill fellowship and spent quite a bit of time in the States.
Have you got any purple trousers? What sort of arrangement of trousers have you got?
So I get the piss taken
Salmon?
at me. I've got a lot of pastel shades. So I've basically got kind of light blue,
green.
I've got a light green and a dark, like a bottle green.
Wow.
I've got white.
Okay.
And we were basically in Dubai at this buffet. The big buffets are the thing on a Friday.
Yeah,
in Dubai.
that's right. Yeah,
and I basically had a tray of
I love buffets.
Of sushi but there was no kind of side plate, so I put all the soy sauce on the main plate. Someone knocked into me, it tipped back, and I got soy sauce all down the front of my white trousers.
Oh man!
And
that is the end of that.
It was embarrassing. My kids don't let me forget it. They still bring it up to this day.
The trouble about buffets is you always end up overeating, don't you? Because you just you have this plate and you start have a little bit of that, a little bit of that, a little bit of that. Before you know it, you've got this massive, literally this unsightly mound of completely chaotic food substances all mashed together, like prawns sitting on top of curry,
sushi and curry, sushi and curry with some chips in there, and often there's dessert in the same plate, so it gets a bit messy. Now, and then basically I'm a senior lecturer here. I do 5 PAs in education. We run the master's program. I'm the training program director for the Royal London rotation, the UK's premier rotation, and other rotations do exist. And then basically, the Masters is kind of one of the main things that we do here, and it's really good fun.
And you've just been voted on to the membership, the leadership of BASC, I understand.
Yes, that we have. Yeah, the thing that 99% of the public were like, "Who gives a toss?" So yeah, but in my sphere, I'm kind of a big deal. I mean, I think it goes.
That is a classic quote.
I think it goes membership of BASC, president of the Royal College of Surgeons,
I'm kind
knighthood.
of a big deal around here.
Not even in my own house am I a big deal. So, listen, we'd better talk about something before this crashes and burns, otherwise we'll be one and done.
All right.
So the concept here is that basically we're hoping to talk about stuff that affects your daily practice and your life, stuff that you can hopefully listen to if you have a commute or a drive. We will link it to the Masters in some degree, and we will have special guests from time to time who bring something extra, something that you and I don't have, which is quite a lot. But So listen, did you ever listen to the Miller audio lectures?
Yeah, I did. I loved those audio lectures.
Yeah.
Those basically got me through my FRCS Orth, my final exit exams. Those I loved. I listened to them in the car as I drove to work. And
Same here.
back.
But the funny thing was that everyone had illegal copies.
Yes, mine were illegal as well. Yeah, mine were copied off somebody else's copy, somebody else's.
And there's like someone who kind of risked their life with his Russian compromat, from East Germany. Someone had got them out, and I probably shouldn't be admitting this, but my exam was 8 years ago, so the statute of limitations has probably expired.
Yeah, I think it does.
Pete, is there anything borderline illegal that you'd like to confess to? It's okay, no one's ever going to hear this anyway.
Well, we've got our departmental night out today, and I think that the frock I've chosen and the makeup I'm going to be wearing will be frankly illegal.
You do dress up as a woman quite a lot.
I quite like dressing up as a lady. Yeah, I do.
This is for the Christmas party. Yeah, this is. But hey, I don't judge.
I feel pretty comfortable in ladies' clothes. They're actually not comfortable at all.
Are they not?
Wearing like fake boobs and stuff. They always chaff, and the frocks never fit.
Yeah.
So actually, it's not comfortable.
Vaseline.
Yeah.
Vaseline's the key, right?
And talc.
And talc. Yeah, clearly, I'm an amateur at this game. An amateur. So today is our second all-day teaching day for the registrars. It's the Christmas trauma extravaganza. I've got my Christmas jumper on.
Yeah, Star Wars Christmas jumper.
And for your talk, I gave you the title, How the Fuck Do I Get Out of This?
Yeah.
What did you think when I gave you that title?
Well, I was trying to put myself in your shoes and thinking, what would be an interesting talk for the registrars. I'll give Pete this talk on what the fuck should I do to get out of this. And what I think you meant by that was you meant the registrars sometimes find themselves in trouble when operating, and what are the common scenarios where people get stuck during an operation and then they can't proceed. They feel like what do I do now? Is this okay? Is it not okay? Should I take all the screws out and start again? Or should I do this? Or should I do that? And I think that's where people get stuck.
And I'm glad that you worked that out, because I clearly didn't make it clear in my instructions. But that's exactly what I had in mind. Because as you know, I famously have never had a complication.
Yeah, no, I've heard.
Never
happened. Never
ever. Never done an operation.
I should come and watch you.
Yeah, you really should. Please don't. And basically, so we started off today talking about the fixed DT, the fixation of distal tibial fractures, one of the UK pragmatic trials that was done here, that was led by Matt Costa when he was at Warwick, I believe.
Yeah.
And basically, they looked at fixation of distal tibial fractures, plate versus nail. And so my take on it, having read that paper, was that at 6 months, which is an early time frame, the nails generally did better earlier on, but at 6 months there was no real difference in what they termed disability.
Yeah, and it's interesting that that's your take on it, because you could have. It's funny how we do these randomized controlled trials, and we call them they are the absolute pinnacle of our, that they are what drives our knowledge is randomized controlled trials
and funding, and the way the direction of travel.
That's right, and you can do meta-analyses of multiple randomized controlled trials, but ultimately it comes down to that is the tier of evidence that you require in order to do a meta-analysis in the first place. So a huge amount hangs on this kind of evidence. I think it's often very easy to be a bit disparaging of research and go, oh yeah, it was a bit of a rubbish study because of this thing or because of that thing, but actually that is the methodologically sound RCTs are the core of our orthopaedic knowledge. I think we mustn't forget that. Anyway, but
agree.
Fixed DT.
What was your take? Because you had a slightly different take to me.
And isn't it funny how your take is often coloured by what your opinion was before you read the paper?
Yeah, let's not bring colour into this.
So if you were to take, so I spoke to Matt Costa about this. He's the main the CI on the paper. Before his assumption going into it was that plates were going to be superior. He thought that nails were going to be inferior because there's more malalignment, because they've all got knee pain from from knocking this thing into their shin bone, and that actually plates put in a sympathetic way would not have a huge complication rate and would have better overall alignment and therefore happier patients. So he thought plates would be superior. I must say, going into this, I thought that nails were going to be far superior because you can weight bear on them immediately. We know it's not a matter for research. We know that the nails are mechanically superior to, or mechanically stronger to plates because they are on axis rather than cantilever. If you see what I mean, cantilever is on the side, on axis down the middle. Something that's down the middle is humongously stronger and more robust than something that sits on the side, if you're in relative stability mode. So my assumption going into was that plates were going to the nails were going to wipe the floor with the plates, and that we'd have an answer on our hands.
And to be honest, I expected to find that the nails mobilised quicker and earlier, that the plates were stiffer in the ankle, and that you'd expect the plates to have a higher infection rate.
That's right, and that's that. Yeah, exactly. That's kind of what I expected as well. What ends up happening is that the nails showed a very short-term advantage, an advantage sort of up to at 3 months, but not persisting through to 6 months. And so that leaves you with that thing of like, well, there was a small difference at 6 months, and even at 1 year, with favouring the nails, but not significant. So that then brings you into, was it powered sufficiently? Was it strong enough? It was 350 patients.
321.
321.
Off the top of my head.
Yeah. And is that strong enough to show that? Because inevitably what happens with when you're comparing this against that in orthopaedics is this starts off being a difference and then that difference dwindles over time.
Yeah.
So once you get past 1 year, it's very unusual for two different treatments to have a long lasting effect, unless it's something to do with arthroplasty where they are long lasting implants that are required. But on the trauma side, you're really looking for early benefits.
And I think one of the reasons why, Matt Costa, perhaps why some people aren't so keen on nails. See, the challenge is, even in my 5 years as a consultant, what we've noticed is that the implants have got better and better for nailing distal fractures.
Yeah, that's true.
In the way that we couldn't have done, 10 years ago. There are now things you would not think about nailing before that you would now.
Agreed. And also, I think we've got better at nailing. We as a community have got better at nailing because we're doing it suprapatellar a bit more now, and even we're doing infrapatellar. We've got a better understanding of how not to contuse the skin and how to make it put it in through a much more soft tissue friendly approach.
When was the last time you did a transpatellar tendon tibial nail?
Transpatellar tendon,
or trans or para?
So like an infrapatellar. Infrapatellar. Oh no, we do them occasionally when the suprapatellar set has got a hole in it or something. So so I quite like doing an infra now and then just to keep my hand in.
Yeah.
But
I have to get a step out.
In my head, it is an inferior operation.
And I agree. And to be honest with you, that was one of the big things when I first came. And I mean, the way that orthopedic trauma has changed and evolved, but also the fact is your experience is coloured by the places that you've trained and places that you work. And I came in, it was kind of almost the default was to do a suprapatellar nail, and I love them. Absolutely love them.
Yeah.
So
my conclusion of the fixed DT, if you want to just nail me down, is that you don't want to nail me down. But anyway, I'm going to tell you.
No,
anyway.
I do. I wanted to nail down about 5 minutes ago. I've stopped caring right now.
Is that I think that nails are superior to plates. And they always were. I was expecting a fixed DT to show a bigger difference, but it didn't. And I wonder whether that is in relation to it being underpowered. And if it maybe had another 500 patients, that would have demonstrated the difference. And I think what we're seeing now is in the latest iteration of randomized controlled trials, particularly the ones coming out of the US, funding bodies are pushing surgeons to go for bigger numbers, not to go for randomized controlled trials of 300, but randomized controlled trials of 2,000 or at least 1,000.
Which is what a lot of the stuff that Mo Bandari's published in the New England Journal of Medicine, JAMA, the health trial, flow trial. I mean, that's where it's going.
Yeah.
I must say, I think it's exciting times in UK for research because the pragmatic trials that we're bringing out, draft, proffer, these things are now really well-designed studies that are helping us to answer some of the challenging questions. And I think it's exciting times. I think it's going to get better and better.
It is. It's really good.
Now, the challenge with the distal nails is that you can really cock it up.
Yeah. So nailing a distal tibial fracture is usually It's usually a short spiral, and sometimes it extends down in the posterior malleolus, usually undisplaced, so doesn't actually make a big difference to your nailing. But they're usually short spiral, but they're coming into the metaphysis. And in other words, they're coming to the area of the bone where the bone's getting wider. And so your nail doesn't have as much control in that area as it did up in the tibial shaft. Nailing a tibial shaft fracture, easy as pie. All you've got to do is make sure the rotation's right.
Yeah, it's like a sawbone workshop.
Exactly. But in the distal, in proximally and distally, that's where alignment is challenging, and proximal fractures are fairly rare. They're not, but distal third tibular, that's your commonest tibial fracture.
And we'll come back to proximal third actually, because that's a very interesting flavour of fracture. Well, that might be a whole separate section actually to talk about. Distal tibia, you've got a spiral going down towards the plafond.
Yeah.
You're not sure if it's intra-articular or not.
Yeah.
What's your threshold for CT?
Oh, pretty low in that setting. Pretty low. I just get a CT, then you can see. You could argue, couldn't you, that why get a CT? Just assume that there's a fracture there, and then you have to worry about it. But the CT does give you exactly where that posterior malleolus. It goes into the posterior malleolus.
Yeah.
Whereabouts in the posterior malleolus it's exiting. So if you are gonna stabilise the block, as it were, with a front to back screw, you know exactly where to point your screw.
Certainly for planning purposes, I think that's ideal. And I think just put a screw in early and then get on with it.
That's right. Yeah. So you fix your posterior mal early doors, and then you can crack.
And then
on.
you've standardised your operation and you've taken out the element of jeopardy.
Yeah.
So give us some. So the risk is a valgus deformity with these low fractures.
Yeah.
And we've all seen X-rays in other trusts that can end up with this valgus deformity. How do you avoid it?
So you're right. Valgus is the deformity that you get most commonly, not absolutely every time, but most commonly in an extra-articular distal tibial fracture. Proximally, we always talk about entry point, don't we? People are always boring on about entry point in the femur, entry point in the tibia for those proximal fractures, because where your nail goes in, that's like a fixed point, isn't it? And so that kind of helps decide where it helps decide what your overall alignment is. Yeah. Similarly, when you've got a distal fracture, it's not the entry point that matters. It doesn't matter where the entry point is, because you've got the shaft in between, which straightens your nail up. The key thing is...
But you still like a decent entry point.
You still like a decent entry point, but it matters much less.
Yeah.
The pivotal thing in a distal fracture is where the tip of the nail ends up. And we are classically taught that the tip of a tibial nail sits in the middle of the tibial plafond, right in the middle. But of course, the tibia wants to go into slight valgus. Now, if just imagine in your head, the distal tibia goes into valgus, where does the tip of the nail end up? It ends up going down the medial mal, or down towards the medial side. The way to correct valgus is not with blocking screws and all that, it's actually just to put the tip of the nail just lateral to the central point of the tibial plafond. Just lateral to the central part of the tibial plafond. So basically, when your nail's going down, if you end up, the tip of the nail ends up bang in the right spot, just lateral to the mid part of the tibial plafond, it is 99 times out of 100, your alignment will be absolutely spot on.
And I remember you talking about this at Percival Pot meeting 4-5 years ago.
Yeah.
And something I'd kind of not really had, and the thing that interested me about that was the conceptualization and the visualization of seeing your distal block and the rest of your tibia proximally, the angle, and just as you described at that time, to basically, I was listening, to basically imagine reducing it, and then with your metawork in situ and seeing where would you want it to end up. And that's why putting your guide wire just lateral to the centre means the rest of it's pretty straightforward. It's quite nice because it's not reduced, nails going down, tock, 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 not reduced, tock, 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 bingo, it's magically reduced.
Yeah. And actually, I would take it one step further, and I would say that it doesn't actually matter where your guide wire goes in the distal block, because I would say, I encourage my trainees not to ream into the distal block. So basically your reamer comes down, it goes through the mid shaft, and chatter, chatter, chatter. And then as the tibia starts widening out again, just stop reaming.
You got space.
Just stop reaming and take your reamer out. And because you often have that problem, don't you, when you're reaming, and then as you pull the reamer out, it pulls the guide wire out as well, which is a real nuisance. You have to stuff that thing down the drill and all that, stop it all coming out.
It's less a problem with newer things. It used to happen a lot. I think it happens lesser nowadays.
Maybe.
But tell me this. Okay, so if you're not reaming into your distal block, and you haven't got a guide wire in there, then how do you control that your nail ends up lateral to the midpoint?
Absolutely, great. So there is a guide wire down there to begin with, but I'm not worried too much where the guide wire is sitting in the block. I've kind of hammered it down when I put it in.
It's just to get you across the fracture.
Just to get you across the fracture, right? So, but literally, you get to the fracture and you stop and you pull it out and you ream up until you've got your size. Your guide wire is down, sitting nicely parked up in the block. You then decide what size nail and length that you're going for, and then you put your nail down. Nail comes all the way down to the fracture site and just beyond. So it's kind of got its nose, if you like, into the distal fragment. Just got his nose in there, and then I knock out the guide wire. So now it's you and the nail versus the fracture, if you see what I mean.
Yeah.
And so now you have someone at the top end who's just going tock, 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 knocking the nail down gently.
Yeah.
And you are down at the bottom end, nursing it into the distal block, and basically you make sure the tip of the nail is aiming directly at the point which is just lateral to the mid part of the tibial plafond, which usually requires you, as you say, to put a bit of varus on the varus force at least across the fracture. It wants to go into valgus.
Just to guide it like here, here,
here you go. And the guy's going tock, 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 and then he's not knocking it all down, like smashing it down in one. Tock, 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 yeah, that's good. Tock, 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 that's good. Maybe get a lateral, and on the lateral it should be going dead centre.
Yeah.
So you've got that kind of the arc of the ankle, and the on the lateral it's dead centre. On the AP, it's just lateral of centre.
So obviously, you have the force. In your mere mortal orthopaedic surgeon, they may be required to call upon a blocking screw wire, a poller screw. Tell me how you do those.
Okay, so
because even you must have to do that at some point.
No, of course, no, you do end up doing pollers now and then. I must say, if I'm using pollers like blockers, then I tend to use wires rather than
like a 3.2
3.2
guide wire or something.
Yeah, something like that, or 2.8 or a 3.2 guide wire. The reason for that is because they're so much easier to adjust. Because if you don't put it in quite the right spot, you just move it. You just like put another one in right next to it and then take that one out, and then they're very, very easy to adjust. Whereas a screw, if you're going to put a blocking screw, it's got to be absolutely on the money, hasn't it?
Yeah, I know. You get one shot and you cock it up.
That's right. Yeah, we have to take it out, and then now what do you do? So blocking screws are difficult to manage, I find.
So let's just visualize a fracture. We're looking straight on a right tibia fracture.
Yep.
Distal third, angulated. The nail's in, and it's in valgus.
It's in valgus, right? So what's happened is the nail has gone down. It's gone down the medial side.
Yeah.
When you look at that fracture, the fracture is in valgus, and the nail is parked not in the middle, not lateral to the middle, but medial to the middle of the tibia. And what needs to happen now, if you just kind of visualize in your head, leave the nail where it is, you would need to swing the
distal block,
the distal block round, anti-clockwise, such that it's now parked up with the nail just lateral of center.
Yeah.
Obviously, you can't do that because it's full of bone. So you have to knock the nail out first before you do that. So you tock it back to the fracture site. You correct your alignment, and then literally just tock it back down again.
And so you're not using a wire at this stage, are you? You're just manually reducing the fracture.
Manually reducing it and knocking it down. Now you can.
But you may have created a path, right? You might have a big hole there that the nail wants to follow.
That's right. Or you may have a very osteoporotic patient where literally the distal block is almost empty of bone.
Yeah.
In which case, yes, I totally agree with you. That's the time where you need a little stud to stop the tip of the nail drifting off medially.
And flick it off.
Yeah.
So
that's going in maybe an inch, but no more than an inch up from the tibial plafond. You're putting a wire front to back, straight down, and that's pretty much maybe just medial of centre.
Yeah.
Of the tibial plafond.
So that it hits that, and you divert it laterally.
That's right. So the nail comes down, hits it, and then gets diverted off laterally. So the tip of the nail, the guide wire is just medial to the mid part of the plafond. The nail ends up going just lateral to the midpoint tibial plafond.
And obviously we don't advocate pepper potting the distal tibia, but with a guide wire you have the option to adjust it if it's not quite working the way
you
that
have
you
2 or
want.
3 goes at it. Yeah, knock it in, doesn't look right, or it won't go past the wire, you've been a bit too greedy, you adjust the wire, try again. Knocking the nail in and out a couple of times doesn't forfeit the fracture.
And I must say the one thing that I would really advocate is that you've got to get it perfect. If it's not quite right, there is a tendency. It might be towards the end of a 3-session list. It might be a Saturday night. There's human nature to go. It's good enough.
Yeah, definitely.
But the best time to correct these, is at the time.
Correct. And you really shouldn't leave theatre until it's absolutely perfect. I have to say, valgus, the distal tibia, is poorly tolerated as well. It's not a happy patient. So yes, okay, it probably will heal up, and yes, okay, they will walk again. But a valgus deformity of your ankle, it's never the same again. You get medial pain. You get it's rubbish.
It will got the whole kinetic chain. It will cause knee problems, hip problems, back problems.
Exactly. Yeah.
And then the problem is trying to revise that later down the line, where there has been some union around it. Can be a nightmare, and obviously infection is a concern.
Yeah. Agreed.
And trying to get these buggers out can be a nightmare.
Yep. Yeah. Agreed. So that's right, and it's so much better just to do an awesome operation first time round, and then nothing more needs doing.
There you go, kids. You hit it first. Just do an awesome operation the first time. Don't cock it up.
Get it right first time.
Get it right. Right, maestro. Shit. Listen. See you next Tuesday.
See you next Tuesday.